Welcome to 2022. It's been an interesting start with the snow this week, so hope everybody's safe and doing well. A couple of quick updates before we get to our speaker. I think people saw in the email, but we are sticking with all virtual for now with the current surge and things, just difficult to get back in person. We are trying to do that as soon as we're able to do so safely, but any questions regarding that, please let myself or Thomas know. Without further ado, just a couple of quick housekeeping issues. We will have the Q&A session at the end of the presentation, so you can still use the chat box or the Q&A feature. If you see a slide that you're interested in, please chat in your questions right away. We'll hold the questions until the end for further discussion, and you can message us if you want to be unmuted to be able to ask your question. If you have any technical issues, please send a direct message to myself or Thomas during today's session. And the CME code will be posted in the chat box. There it is. And at the end of the session, we will repost that and the QR code for attendance. Just a brief reminder that today's sessions is recorded. It is available on the Department of Internal Medicine Grand Rounds website, as well as future schedules and topics. So for today, today's Grand Rounds is sponsored by the Department of Hospital Medicine. And so we want to thank Dr. Alan Dow for inviting Dr. Carlyle to speak with us today. And so today's topic is applying the trauma-informed organizational model to internal medicine, and is presented by our colleague, Dr. Kellie Carlyle, over in the Department of Health Behavior and Policy. Dr. Carlyle is an associate professor in the Department of Health Behavior and Policy in the School of Medicine here at VCU. She serves as the scientific director for sexual and domestic violence research in the VCU Institute of Women's Health, and is a founding member of the Decriminalization of Trauma Interdisciplinary Research Group. She focuses on public health approaches to violence prevention and is currently co-PI on a $2 million federal funding from the Centers of Disease Control and Prevention and the Department of Justice. She serves as the inaugural Medical Education Faculty Fellow in the Office of Faculty Affairs in 2019 to 2021, where she focused on trauma-informed approaches. Dr. Carlyle also holds certificates in medical education and trauma-informed organizations, and is currently pursuing her Master's of Education in Educational Leadership. Dr. Carlyle, we are pleased to have you today and look forward to a different perspective, and I think we could all benefit from. So thank you so much for speaking with us today. Thank you.
Thank you so much for this opportunity. Let me go ahead and share my screen here. And let's see. Back on one. And I am happy to make a copy of the slides available after if anybody is interested. So thank you for that warm welcome and introduction and spending time with me today. I don't have any conflicts of interest to disclose. I wanted to start by acknowledging the Buffalo Center on Social Research. They have an Institute for Trauma and Trauma-Informed Care, and that is where I did my certificate in trauma-informed organizations last year. So they have a trauma-informed change manual, which can be accessed from this link, and much of the figures and the information that you'll see today comes from their work. So I just want to start by acknowledging that. So it feels a little bit on the nose to be talking to you today about trauma as we head into year 3 of a pandemic. And I'm sure, like most of you beyond our jobs, we're people in all of this and facing a lot of decision fatigue. You know, I have a child that's too young to be vaccinated, a child in elementary school, a child in high school. I have an elderly cancer surviving parent who lives with me. And so every day I'm thinking about, is this place safe? Is this activity safe? And it's overwhelming. And I think a lot of us really feel that. But my interest in trauma didn't come from the experience with COVID. It came long before that. And what COVID has really provided us all with is this chance to engage in empathy with people who have experienced trauma in a very different way. Because when we think about people of color or people experiencing family violence or people experiencing all sorts of different types of trauma, what we're experiencing during COVID is what they have experienced every day. The concern of, is sending my child to this place going to be safe? Is interacting with this person going to be safe? There are a lot of people for whom our structures and our organizations aren't safe. And so, when we think about trauma-informed care, especially in the healthcare context, we often just think about it in terms of our patients and how we interact with them. And that's absolutely important. But I want to start by highlighting the interconnections and why the organizational approach is really important. And so, we start these presentations giving all of my the background and credentials. And then what you don't see and what's not in those introductions is that I'm also the first in my family to get a PhD. I grew up in Flint, Michigan. I have an ACE score of 6. To this day, my only sibling remains incarcerated. And so understanding that there's not as much difference between your colleagues and your patients, there isn't an us and them, is really important perspective. And to understand that your colleagues are likely as impacted by trauma, COVID aside, as some of your patients might be. And so by taking this organizational approach, we put those things together. It's hand in hand and looking at what is this whole culture of our organization and how can it benefit not only patient care, but your workforce, your learners, and all of those things together. So that's kind of the framework I want to approach this with. And so today we're going to talk about what are these core components of the trauma-informed organizational approach. What are our 3 levels of that? What does it mean? Our little umbrella metaphor. What do we mean by universal precaution? And then being able to identify what are some of these system factors that can contribute to re-traumatization among your patients or among your colleagues. And then really kind of end with what are some tangible steps that your unit can take to reduce re-traumatization among your patients, among colleagues, among learners. So when we talk about a trauma-informed organizational approach, it really is at this cultural level. We want to shift our entire organizational culture to align our policies, our procedures, and our learning spaces with these trauma-informed approaches. It's also recognizing that these are skills, these are things that can be learned, and they're not things that everyone is born knowing. And so a big component of it is providing training to faculty on trauma-informed approaches, which include communication and mentoring skills. And that doing so, this understanding that the payoff is this is going to bolster resilience among your patients and among clinicians with trauma histories. It improves patient outcomes, adherence, engagement in treatment plans, that it's a benefit to everyone. So when we talk about this organizational approach, we like to talk about our 4 R's of trauma-informed care. The first is realizing that people at all levels can understand trauma, that it affects individuals, families, communities. Just this idea that this is pretty widespread, that it isn't just someone from a certain community, that it is your colleagues, that it is everyone. This is very widespread. 2, being able to recognize. So everyone within your organization should be able to recognize the signs and symptoms of trauma. And this includes front office staff, anyone who's interacting with patients. So if you're seeing someone who is really upset, who is belligerent, how are you making sense of that situation? Is that because there is something about the person's personality, Or is it a trauma response? Are they overwhelmed? How can you understand that situation and respond to it in an appropriate way? Takes us to number 3, responding. Programs, organizations, and communities respond by practicing a trauma-informed approach. And you'll hear us say a lot, it's that shifting of question from what's wrong with you to what happened to you? And then how do we make sense of that? And then the 4th is resisting re-traumatization. So there's a lot that we do in our organizations that compound trauma unintentionally, in most cases, unintentionally re-traumatizing. And so really being able to look at our policies and our practices and identifying, are there ways we could improve this to avoid re-traumatization? And so when I talked about this manual that the Institute at Buffalo has, it's pretty extensive. And when we talk about actually doing a trauma-informed organizational assessment, that's not something that can be covered in a 1-hour seminar. It's an entire undertaking. So if you look in the green column at sustainability, it gives you the kind of key development areas: leading and communicating. So if you want to have a trauma-informed organization, it starts at the top. You have to have buy-in from organizational leadership. And last year I had the privilege of being selected as the School of Medicine's nominee for the Macy Faculty Scholars Program. And even though I wasn't ultimately chosen, it was a great experience for me to be able to interact with our administration and really have a sense of their priorities. Because my project was doing just this, doing an assessment of all of our School of Medicine practices and policies from this trauma-informed lens. And it was something that was endorsed not only by Dr. Buckley, but by Dr. Kellerman, by leaders across the health system. And so this trauma-informed organizational approach is very consistent with VCU values, with our goals of being a high reliability organization. And it's very consistent with our approaches to diversity, equity, and inclusion, right? And particularly our anti-racism work that we're currently engaged in. So this is something that, VCU is a great place to engage in these approaches, and this is a great time to really learn about and lean into these. But because we can't do all of this today, I'm going to give you some highlights about what we can do. Okay. So overall, it's an organizational culture change. When we talk about trauma-informed care and trauma-informed organizations, this requires the traditional power hierarchy to be more flattened. And that is very challenging to do in a discipline like ours, especially in an academic environment. That is not what we're accustomed to. But this collaborative environment is very important to a trauma-informed approach, recognizing the value of what each person brings to the table. This paradigm shift of moving from what's wrong with you to what has happened to you in everything we do, whether that is how a patient is reacting or whether that is a colleague snapping at someone, especially now in year 3 of a pandemic. If somebody snaps at somebody, yes, you have to address that, but maybe start with, tell me what's been going on. That's uncharacteristic of you, and this has been a really stressful time. So let's start with what's going on, and then the symptom of what happened of snapping at somebody, right? So it changes how we react and how we view situations. When we talk about a trauma-informed approach, there's generally 3 levels, and sometimes you'll see this depicted as an umbrella, where being trauma-informed is kind of this overarching awareness of the prevalence and the impact of trauma, right? That it is all around us. A lot of times when I talk about this, it's in the context of our learners, and folks are always surprised to hear that not only do most of our learners have experience with ACEs, we have about 3% of our undergraduate population and 2% of our graduate population who've experienced sex trafficking while enrolled at VCU. And so we are not immune to any of this, being in academia and being learners. So again, recognizing that trauma is all around us and engaging in this idea of a universal precaution, which we'll talk about on the next slide, for re-traumatization, and anchoring in our 6 guiding principles. Trauma sensitive, when you're moving in, that's deliberately looking at all of our levels of operation, responding to other people in a way that is sensitive to potential trauma histories, whether you know that history or not. And then what we're probably more accustomed to is this trauma specific, right? So evidence-based trauma treatment interventions that are specifically designed to treat individuals and help them heal from trauma, right? Because how you're going to address someone who has experienced sex trafficking is going to be different than someone who's experienced the trauma of loss of a child. So we want to move through these levels. So when we talk about this idea of a universal precaution, they use the metaphor of all of you. You're putting on your gloves. It's safer for you, it's safer for your patients. And so a universal precaution is this idea of we're putting on our metaphorical gloves. We're changing our interactions. We're changing the lens that we view things through to prevent this possibility of re-traumatization. Very similar to this idea that we use in learning about universal design, or things like the idea how elevators were designed for people in wheelchairs, but really they benefit everybody. Universal precautions are things that benefit everyone, regardless of their trauma history, but really takes that into account and just shifts your lens again and how you're viewing the world. So, our core principles of being trauma informed. And if you look at the manual, they'll talk about 5 core principles. SAMHSA updated that to really include cultural, historical, and gender issues several years back. And so when you look at trauma-informed organization approaches and work from SAMHSA, you're going to see the 6. The way that Buffalo talks about it is they place cultural, historical, and gender issues kind of as a circle, as a context surrounding all of this. So if you're going to interact in a trauma-informed way, we're going to need to think about these 6 things. So when we talk about safety, we don't just mean your physical safety, we mean also your psychological safety. And so you can think about all of the ways that we use space. For example, if you're walking into a patient's room and they're in a hospital setting, you're already probably going to be standing above them. If they're in a bed, you're going to be between them and the door. So there's already the proxemics, the way you are situated in that room can feel very overwhelming. If you think about someone who has a history of, for example, sexual violence, just being trapped, feeling that feeling of being in that room, not having an escape route, having someone in between them can feel very threatening. So thinking about where you're standing, right? Even moving to the foot of the bed so that you're not between them and the exit, or the things that you already do, like knocking before entering, introducing yourself, doing what you can to make the space safe. But this also goes for the other ways that we use space and set up our environment. So whether you have, for example, a safe zone sticker or a pin on your coat. So we have safe zone trainings at VCU, and you have the triangle sticker that kind of shows that you have some cultural sensitivity, that you've had some training on how to interact competently with sexual and gender minority populations, or if you're asking somebody their pronouns, that adds a level of psychological safety. If someone's coming into the waiting room in your clinic and there is Nothing that isn't in English, right? That might be very off-putting to some, or thinking about just the images and how you have things arranged. Is there an opportunity to come and speak with front office staff with some privacy without people hearing about what your concerns are? Things like that, that first impression and how you're using space really contribute to feelings of psychological safety and of physical safety. When we talk about trustworthiness and transparency, so transparency is a lot about in your decision making or why you're doing the things that you're doing. And that could be why you need to do a certain test or procedure, or particularly if you need to put your hands on a patient or to engage in something that might be painful. Having transparency in that and asking permission and making them aware of what's coming up. Trustworthiness is one that I always struggle with, because mentoring is my passion, and I always think to myself, well, why would a graduate student ever be hesitant to come and tell me something if something was wrong? I'm a nice person, I'm very approachable. What's the deal? Because it's easy to forget that people, especially in our first few interactions, they're not seeing me, they're seeing a cisgender white woman and all of their experiences with other people who may look like me or may be in positions of authority and what those interactions were like. So remembering that trustworthiness is something that has to be earned. It's not an assumption. And so thinking about in your interactions with patients, how can you establish that trust? And we'll talk about that in some of the communication skills in a little bit. Collaboration and mutuality. And so this, when we think about it from a patient perspective, we often talk about it in terms of shared decision making or engagement and treatment decision making, which is not always what the patient wants, right? So having that conversation with patients, how much input do they want to have? How are you engaging them? How are you respecting their expertise of their own lives, of why maybe a particular lifestyle change or treatment approach might not work, might not be compatible. But it's also in how you interact as an interprofessional team, right? If a patient is watching you do rounds and the medical students are clearly afraid to ask questions, or you're berating them, why would a patient feel comfortable asking you a question, right? It's all about the interactions and all of the watching that people do. I had the opportunity to be in the hospital quite a bit over the last couple of years, just with my father, as he's had various surgeries. And I knew everything I needed to know about the surgeon before I ever met them by how the nursing staff and everybody else talked about that person and interacted and anticipated that. I always say, for me and for my ethics, I tell much more about a person by how they treat the custodial staff than the chief of staff. And so just being aware that your patients are watching all of these interactions. It's not just when you're with them. And so you can't engage in trauma-informed care for your patient if you're not engaging with your colleagues and with the entire organization in that same way. Peer support. So this can mean a lot of different things, but connecting patients sometimes with literal support groups, letting them know that they're not alone, helping them tap into different support networks. So being aware in general of either what are the resources at VCU or who knows about them, right, that you can send them to, and being respectful when people do want to have a patient navigator or someone like that in there for support. Empowerment, voice, and choice, exactly what it sounds like. So giving people the information that they need in a way that they can understand to be able to make informed decisions, giving them choice. This is particularly important in the areas where I work, with sexual violence, whether or not someone's going to do a forensic exam, whether they're not they're going to have that evidence submitted, that has to be about choice, right? You're going to have a lot of patients who are coming to you because they didn't have a lot of choice in how they ended up there. And so being able to give some sense of autonomy, some sense of engagement and power back to them, that they can engage in their health and do it in ways that, when we talk about empowerment, we talk about resilience. It's not focusing on, oh, I'm so sorry, all of these terrible things have happened to you. Yes, and wow, look at all of the strength that you've had to be able to overcome those things and still get to where you're at. Let's look at some of those skills that got you there and how we can use them to help you stay even healthier. So recognizing those strengths in folks. And then cultural, historical, and gender issues. Really understanding, and I think, more so than ever, we have this awareness that how we treat certain people based on their various identities can be a source of trauma, right? And especially when we talk about our interactions with the healthcare system, we've talked a lot about this at BCU. Not everyone's experience has been at all positive. And we need to do the work to rebuild that trust and not take it personally if someone comes in and is hesitant to engage, or you can barely get them to come in, or they don't want to be in your clinical trial. There's probably very good reasons for that. And it's on us to figure out how to address that, how to make our systems and our spaces safer. In thinking about who patients might trust. An example from BCU, the Injury and Violence Prevention Program in trauma does a really nice job of this with a lot of their programs around violence prevention, where they have credible messengers, right? So you're having people from the community, or this idea of community health workers. So going hand in hand, how do you use your cultural awareness and engage people in the healthcare process who may not be healthcare providers, to help build trustworthiness, to help make people more comfortable in engaging with all of us. So, we talked about some of these examples, but this kind of gives you a table of what are some of the system factors or the relationship factors that can lead to re-traumatization. So having to continually retell their story. Back when I was doing my PhD training, I worked as an advocate providing hospital accompaniment during forensic exams. And one of the things they always made sure to do was have the detective and the forensic nurse together when the patient told their story, so that they were telling it once. And so the detective had what they needed, and the nurse knew where in particular they needed to look for evidence, what types of treatments were going to be most appropriate. So thinking about ways that we can communicate interprofessionally, especially in situations where there might be a lot of trauma, to not have to continue to retell that story. Being seen as a label, right? Addict, schizophrenic, talking about people as people and not about a condition. Recognizing that things like substance use are often just maladaptive coping mechanisms, right? Not feeling like you really have a choice in the service or the treatment, or not having access. And so when we're making recommendations, doing that with the mindset of, will this actually be accessible for my patient? So are there going to be translation services? What are the healthcare, health insurance requirements? And knowing, again, you don't have to know everything, but knowing who on your team is going to have that information and can help them navigate those processes. Having practices without cultural considerations is a big one. And I'll spend some time on some strategies of how can you be more culturally competent. Oh gosh, not being seen or not being heard. We hear about this a lot. So taking the time, when you are asking a patient, do they have any questions? Did you stop and make eye contact when you asked that? Or is one hand on the door and you're on your way out of the room? Because that body language is communicating something very different than what the words are saying. Or when you are screening someone for depression, for reproductive coercion, for domestic violence, how are you approaching that? Are you saying, you're not experiencing any violence at home, are you? Or not looking up from your clipboard when you say that. And I can't tell you how many times I've been screened in this way by providers. That's not inviting a true answer, right? So being mindful of taking that moment to just look at the patient, be present, hear what they're trying to tell you. Victim blaming is something that we hear a lot from patients, especially, a different example, like fat phobia, right? You might come in for a cold and somehow that gets related back to obesity. Obesity might be an issue that needs to be addressed, certainly, but that's not the only issue, and it shouldn't always be the primary issue, and it shouldn't be the primary lens through which you see a patient, right? Thinking about microaggressions, the names that you use of how you address people, things of that nature. So there's lots of things that we do that are unintentionally re-traumatizing. Just to give a couple examples, even thinking about our learners. And we've had a lot of movement around what a doctor looks like or what a surgeon looks like, expectations around what is professional, not always realizing that what might traditionally be seen as professional is also pretty expensive, right? That wearing a suit or wearing all these other kind of more formal attire is not something that everyone can afford. And then it is not always something that represents somebody's culture. And it's not something that often helps relate for a lot of different patients. And so even kind of breaking down how we think about something as basic as professionalism and what lens are we using to define that can help us start to unpack how we might be unintentionally re-traumatizing folks. So I have had the opportunity the last couple of years to do the Communicating Respect lecture to our M1s. And I wanted to share a couple of things that I share with them, so it gives you an idea both of kind of what your learners are being taught, and it also gives some really tangible examples about how we can start to move away from traumatization and move towards this kind of universal precaution using some of our communication skills. And I start always by giving this example of why is this even necessary, right? So as recent as 2015, a surprising number of first-year medical students still express some implicit bias against gay and lesbian people. 50% express explicit bias. right? And when we look at the history of sexual and gender minority patients in the United States, there is a long history of stigma and oppression, of policies that minimize their access to healthcare, just a lack of healthcare engagement, getting inaccurate information, microaggressions. So, we have a lot of awareness around some of the historical mistrust with Black communities, but this exists for a lot of other communities. And so there's a lot of really good reasons why some of our patients might have some hesitation around trusting us. And so when we talk about some of the basics for showing respect, introducing yourself by identifying your pronouns. So you'll see in my name here, it has she, her pronouns. So kind of getting into that habit, right? Asking patients how they prefer to be addressed. Name, pronouns. Practice using they and them pronouns in everyday conversation. It might sound a little bit awkward at first, but just use it. And it will start to roll off your tongue a lot easier. So why is this important? Well, if you start an interaction by misgendering someone, or if your front office staff does, you might be the most SOGI competent provider there is and have great empathy and be exactly the provider they need. But if your staff dead names someone in calling them back or misgenders them, they're probably going to leave before they ever get to you. And so, being that example in your practice, instead of having someone, calling them back by saying Mr. Smith or Mrs. Smith, say Patient Smith, right? Simple changes. This is how the next generation is being taught because it's much more inclusive. It also avoids some gendered things, right? Ms., Mrs., Ms., all sorts of reasons why, again, asking pronouns, asking how people want to be addressed is a nice universal precaution. It's universal design. On your forms, asking people how they want to be addressed, affirming gender identity, and mirroring patient language for their partners, right? So especially, if you have same-sex partners, not always referring to someone as, oh, your friend. If they've referred to them as my partner or my spouse, referring to them as your friend can be extremely inappropriate and affect the whole interaction. Same thing when you have somebody coming in and you're trying to make an assessment of their safety. Don't assume that the person who's with them is the same sex, that it is a friend. It could be a romantic partner, right? Again, ask and don't make assumptions. Avoiding gendered pronouns in your greetings unless you know their gender identity, and then that's fine. Use the pronouns that they want. When you misgender someone, you apologize and you move forward, right? When you dwell on it and you keep apologizing over and over and just, that's actually putting the emotional labor of making you feel better onto the person. And that's not fair to them. So you apologize and you move forward and you do better. Being willing to say you don't know the answer, right? Things are constantly changing, and there might be an aspect, for example, of transgender care that you're not aware of what the best practice is. You can say that and say, but I'm going to look into that and I will get back to you with an answer. And then again, kind of understanding the changes and the importance of language and avoiding terms that have pathologized your LGBTQ patients before, right? Your preference versus orientation, transgendered, not appropriate, transgender. LGBTQ is not a lifestyle, things like that. So avoiding those terminologies will change your whole interaction, change the engagement in the process, and ultimately make your job a lot easier because there is going to start to build that trust and be more likely to want to engage in the treatment options that you're giving. An example for Muslim patients, and again, each of these, you can see that the care for Muslim patients is a hyperlink, and a lot of our national organizations have really made this easy for us and created these one-pagers of here's some basic things to know, right? So whether a healthcare provider, when possible, should reflect the same sex of the patient, or recognizing that things like handshakes between members of the opposite sex, that's not a sign of disrespect. If that's refused, it's a sign of modesty. Something that it is not, these last couple are not just for Muslim patients, but in general, the patient might want you to communicate with other members of the family present. That might be the culturally competent thing to do. But you ask the patient their communication preferences, who they want to have involved in the interaction. And then respecting modesty, right? After you knock, give the patient time to cover. If you're doing physical exams, do it step by step, ask permission, right? Uncover and recover as needed. This is particularly important for sexual assault survivors, right? So just these small things, if you do them with everyone is going to be more comfortable. Same thing with folks with disabilities. Always addressing the patient first, right? Ask them permission for their caregiver presence. It's still, again, that idea of choice, right? Sometimes caregivers can be very assertive or overwhelming or dominating. And I say this as my father's caregiver. I can dominate an interaction, and you got to be careful. I got to check myself. And the physician talks to my father first and then looks to me, right? So talking to your patient directly, even if there's an interpreter, your eye contact's with that patient, right? Or engaging in triadic communication. And again, asking them their communication preferences. These are just some tangible things that you can do as an organization, as an individual, to make practice that will resist re-traumatization. And so we boil it down to communicating respect. And this is very consistent with a trauma-informed approach. Responding to the patient's emotions and concerns. In all of my research in why healthcare providers do or do not screen for domestic violence, the main thing that comes up is I don't know what to do with the yes. And recognizing that what we always tell back to them is you don't have to fix the problem. Your job is identifying that and validating that. Same thing with patient's emotions and concerns. I'm sorry that this has happened to you. No one deserves to be in this situation. Let me connect you, right? Your role is that connection. Encouraging your patients and recognizing their accomplishments. Maybe I didn't lose those 40 pounds you told me, but I lost 5, and that's a good start. And so let's focus on what I did to lose those 5 and how I can build on that, right? Sharing the informed decision-making process, informed versus shared. So again, assessing how much your patient wants to kind of rely on your expertise versus involve their own decision-making, involve family members or close friends. Promoting an environment that's inclusive of diversity, right? Again, in your surroundings, both physical, what are the symbols, what are your pictures, what are the images, all of these things. Empowering patients towards self-care, again, focusing on that resilience, on their strengths. Creating a relationship based on healing. And for those of us who are in this kind of violence prevention world, we've actually kind of started moving away from trauma-informed care to healing-informed care, from screening to assessment, from mandated reporting to mandated supporting, because those language differences matter, right? And we want to foster healing. And then lastly, treating the patient as a person, not their condition. They're a person. And then just to tie that all together, again, reminding yourself that it's not just the patients, right? That there's a huge impact on the healthcare workforce. I don't think I need to tell any of you about this, especially now, but recognizing again that beyond their own trauma histories, we are in year 3 of a pandemic and we are tired And so think about that when you think about how you're interacting with your colleagues, when they might have an off day, and how you're responding, how you can reaffirm kind of their worth, their purpose, and their need for rest. So if we put this again all together, Virginia Heals in the Virginia Department of Social Service is an organization that we're working with as part of our Department of Justice grant. And they kind of put it all together. What might a trauma-informed model of service delivery for children, even families, look like? Again, talking about reviewing your policies, engaging families meaningfully, training your staff, giving people the tools so that when we say go be trauma informed, you know what that means, and you have some ideas about how can I do that within the constraints of my specific job. Right? Identifying services, so understanding your community, right? That, again, you're not going to do it all, but having an idea of where are those support services and who on your team knows about them. Screening for trauma, screening everyone, right? We're really, when you think about our ACEs and what those are, they're all grounded in our social determinants of health, right? Where we live, work, learn, play, grow, all of these things are just intimately connected with our health. And so if we're not talking to all of our patients about these things, then we're missing a big piece of the puzzle, right? And making referrals, right? Knowing who your team is across the community. Knowing that if you have someone you suspect is being trafficked, who can you call? Right? So it gives you a way to put it all together. And because in public health we love our graphics, this is how we end by putting it all together in this graphic. So in the middle, you have these 5 principles: choice, empowerment, safety, trust, collaboration. That is the core of it, right? You want to have your 4 R's, realizing that it's prevalent, trauma's everywhere, it impacts everybody. You should have some basic skills on how to respond to it so that you can resist re-traumatization. Within that context, your relationship with your colleagues, with your learners, with your patients, those all matter. You want to show a lot of respect for the resilience and have this be an asset-based approach, being mindful of gender, of cultural and historical context, and how those provide a framework or the lens through which a lot of your patients are approaching your interactions. And doing that from this trauma-informed environment where all of our policies, our environment, our people are taking this universal precaution to shift how we are engaging in our interactions. For any of you who still haven't bought into this, I like to close with an article from Dr. Humphrey, who is the head of the Harvard Macy Foundation, talking about psychological safety. It is a science-based best practice. It's not coddling, especially when we talk about our learners, right? The highest performing teams report more errors when they do not feel retaliation or judgment, right? And so again, even though some of this might feel counter to what is maybe been normative or how we were trained, the evidence really supports these approaches, both in patient outcomes and in improving our learning environment, which would improve the diversity of our trainees, their satisfaction with the environment, their retention. And my favorite quote from her right here that we end with, right? This is not a contradiction, right? Emotional support and excellence go hand in hand. So thank you for your time and for your attention. I'm going to stop the screen share so I can maybe see some faces or catch up to the chat, but I'm happy to take any questions that you might have.
Thank you so much. Great presentation. Really appreciate the perspective. I have a few comments and questions, but I'd like to hear from other people first. And Dr. Dow, you certainly feel free to add any comments.
I've appeared, Christian. Kelly, great talk. Thank you for doing this. The sex trafficking numbers always startle me whenever I hear them. And so could you maybe say a little bit about that? So many of us, we care for our patients sort of itinerantly, where we, in my case, see them in the hospital for a few days and then maybe never see them again, or maybe we see them every several months as a specialist. So can you give us some sense of how to do a better job of trying to identify people who are victims of sex trafficking, and sort of, how to navigate those processes? Because that's always something that just boggles my mind when I hear those numbers.
Yeah, and there are some great people in OBGYN who have been working on this, and or who have been trying to do more trainings. And so things like really thinking about who are the people with the patient, right? If someone is speaking exclusively for the patient, kind of cutting them off. If the patient doesn't seem to really know where they are in terms of what city they might be in, or they don't have access to their own identification or cards or things like that, or if somebody is constantly looking to the person in the room before they answer a question, those are all red flags, whether that's for sex trafficking or any other type of violence. And as recent events in the news have reminded us, that it's not this heteronormative thing, right? It might be a woman with a female who is the person who is trafficking, right? A lot of these are pyramid scheme is just what kind of comes to mind, but it's the same sort of idea, where there are youth who are trafficking other youth, and there are people of the same gender. They're not always going to look like what you expect to look like.
Thank you. Other folks in the audience, anybody, you can ask to be unmuted or just chat in the box. I have a comment and maybe a response. Just in light of the last 2 years with just a lot of virtual interactions, I just wanted to touch on a point when you said interacting with others. And I wanted to know if you have seen a change in behavior, human behavior in general, because we have had much more virtual interactions through Zoom, and the idea of microaggressions through emails and things like that. And if you are observing that kind of behavior spilling over into the clinical domain, may be hard to separate from provider burnout as well, but wanted to know if you have seen any, in light of our pandemic and less in-person interactions, have you seen any worsening trends in the last 2 years that you think we need to autocorrect?
My disclaimer is I'm not in a clinic, but kind of colloquially, in the ways that I've been looking at it, it has been kind of in the K through 12 context, looking at sexual misconduct with teachers. But when I think about just kind of colloquially what I've observed and what I've talked with colleagues, I think there have been both benefits and drawbacks. And so from a telemedicine perspective, particularly like a lot of mental health providers have been online, people have been much more in tune with nonverbal behavior. And I think in some ways, telemedicine has actually kind of improved some of those interactions, because people are not as distracted by other things going on, and you're not kind of walking out of the room as you're talking or things like that. And so you can get a different sense of your patient when you're focused on just this piece of them, but also seeing pieces of their home and what's going on. And if there are people who are kind of in the frame, or what that looks like, it's giving people, I think, a different perspective on patients. Again, that's presuming that cameras are on. When cameras are off, it's a very different situation.
Thank you. I was wondering, I think one of the more powerful one of your slides is the re-traumatization slide, where you have system and then relationships. I think there were 2 columns. I was wondering if you could put that back up for a second, because we are in an academic medical center. We have lots of learners involved in the clinical arena, and you know, oftentimes with sensitive topics, we try as best as we can, but I saw a lot of things on there that we probably could do better. And so I was just wondering if you had anything like, so there are a number of things here on both the left and right side. And I think, just as a background to our closing discussion here, I encourage people to take a look at this again and see if there's anything we can do better. But if you were thinking about the hospital environment, let's just picture the emergency room, which is one of the most disruptive and challenging environments to practice in and interview people. Just a lot of moving pieces, lots of people coming and going. Is there anything that we can do better? So just the background, instead of going directly to the patient, so internal medicine gets called down to admit somebody to the hospital, right? The question is, do you go directly to the emergency room provider to get additional story and history, or do you go into room and get a kind of fresh take on the issue that you were called about? And I was just wondering if you had any comments around that, and certainly Dr. Dow can certainly chime in, but yeah.
It's hard to give a universal recommendation on that. I think that checking in terms of, is there anything I need to know before I go into this room, right? So kind of cueing into, is there a family dynamic, or is there something that has given that emergency room physician a red flag, that being aware of that might change how you enter the room or think about or understand that patient and the history. There is a benefit to having those fresh eyes, but again, if it's a particular, I mean, it's the emergency department, so a lot of it is going to have some particular trauma around that, and knowing if you know, there might be police involvement or social worker involvement or things like that that might make a patient less comfortable in giving you the information you need. I think that's helpful to know going in, and thinking about who else might need to be in that room to help you get the information that you need, whether it's a community health worker, a caseworker, an advocate, to really put that patient in a space where they can give you what you need to give them the best treatment possible. Alan, did you have anything to add to that?
I mean, I really think the organizational and interprofessional way of looking at this is spot on. So I'm glad we're having this conversation and starting to think about it this way. So, and we're about at the top of the hour. Christian, so I'll let you take us home.
Yeah, thank you so much. And Dr. Syme, did you have any comments before we close out?
No, just that was really just a super presentation and incredibly helpful. I think it makes us all think. So I really appreciate that, and certainly should not be, I think, the end of this conversation, but just the beginning.
Well, thank you so much. I will create a PDF of my slides and share it so it can be distributed to listeners. And I'm always happy. I'm around, happy to engage with you more, help as I can. Thank you so much for your time this afternoon.
Thank you.
Thank you, Dr. Carlyle. We appreciate that. For everybody else on the call, the CME code, we will repost that in the chat room now, and Thomas will put the slide back on with the QR code for attendance. But that's the end of the session today. And again, welcome to 2022. We look forward to next week. Thanks, everyone.